Hello, everybody. Good morning, good afternoon, and good evening, and welcome very much to our World Hepatitis Day webinar, done in cooperation with World Hepatitis Alliance, DNDi, TAG, and Coalition Plus. Next slide, please. So I'd like to go over the agenda of what we will be talking about today. So first off, I am Sanyel Scholten. I'm the Deputy Head of HCV Access here at FIND. So I'll be giving you opening remarks and kind of positioning our discussions today. And then we will hear from Professor Sean McGum and Jean-Michel. After that, next slide, please. We will get to the real substance of today, which is a session moderated by Dr. Philippa Easterbrook. And it will feature many of our partners from our country work for the Head Start project, and then followed by a Q&A session on that. Next slide, please. Following, then we will have a community awareness and mobilization session, where we'll hear from Bryn, Maria, Anushia, as well as to watch an excellent video done by Coalition Plus about the importance of community workers, especially in the context of COVID-19. Next slide, please. So a little bit of background about FIND. So FIND, the Foundation for Innovative New Diagnostics, is a global nonprofit driving diagnostic innovations to combat major diseases affecting the world's poorest populations. We have offices in Vietnam, India, Kenya, South Africa, and Geneva. And currently we focus on 6 disease areas: AMR, neglected tropical diseases, hepatitis and HIV, pandemic preparedness, which is including COVID-19, malaria and fever, and tuberculosis. And so we work to develop end-to-end solutions to diagnostic gaps and problems. Next slide, please. So what is the need for hepatitis C? Now, if you have been attending some of the other fantastic webinars that have been going on in the last 2 weeks for World Hepatitis Day, you might be familiar with this graph. And so what this graph is showing us is that there's an estimated 71 million people living with hepatitis C. However, as of 2016, less than 15% have been diagnosed. In order to reach the WHO 2030 targets of 90% of those infected diagnosed, we have quite a way to go. Next slide, please. So what do we need to do here? Well, we need to find the missing millions, we need to link them to care, and we need to do it in a cost-efficient manner. You know, cost efficiency is always important in any public health program or project. And it's really important in the context of hepatitis C because there's no large global funding bodies to address hepatitis C, and funding is maybe not at the same level that there is for other diseases. This means that governments who are addressing hepatitis C have to use their domestic budgets, and governments have a lot of different concerns and to think about when they are making their budgets. So showing that hepatitis C care and treatment is not only cost efficient, but often cost savings is really important to do. Next slide, please. So how can we do it? Well, we need to do decentralized risk-based screening at places people already go for care, with reflex testing for RNA and liver staging, and decentralized treatments. Next slide. So a little bit about Head Start. So Head Start is hepatitis C elimination through access to diagnostics. It is a project funded by Unitaid, started in 2017, and it completes at the end of this year. And it focuses on 4 main areas. The first is our research and development. So to increase the research and development pipeline for tools available for hepatitis C diagnostics. The second is the in-country work, and that's what we're going to be speaking a lot about today. So that's the demonstration and pilot studies. The third is market forecasting on HCV diagnostics. And lastly, we have evidence sharing to inform global, regional, and country policies to support the use of decentralized, simplified, and integrated HCV diagnostics. Next slide, please. So a little bit about our R&D portfolio. We're not going to focus on that today, but I just wanted to give you a kind of taste of what we're working on. So it likewise is marked into 4 work streams. One is the HCV molecular point of care technologies. So that ranges from things such as the Gene Expert fingerstick assay, which attains CE marking through using data that was provided by FIND independent evaluations, to looking at the Gene Drive platform and intended settings of use. That study has just been completed in Cameroon and Georgia. And also the development and then evaluation of the MolBio HCV point of care assay. Our second work stream is the serology work stream. And so this has covered optimizing existing RDTs. One of the things we did was the largest, as I know, retrospective study of 13 different HCV RDTs, both mono and co-infected samples. So that's people living with HIV and HCV to understand the performance. This also contains our self-testing work stream. This is looking at self-testing prototypes for both oral and blood fluid. Our third work stream is the validation of dried blood spot samples, and that is for both AYA as well as RNA. If you may have been lucky enough to catch my colleague Emmanuel yesterday on a webinar discussing the results of our study for the Abbott DBS, we're also looking at Hologic and Roche. And now this is an evaluation of the manufacturer provided protocols as opposed to the off-label use that maybe some countries or projects are currently using. Lastly, we have our core antigen. And so this is mainly looking at the development of a core antigen point of care RDT. Next slide, please. So this is another way of looking at that same pipeline, kind of broken down into our mantra: simplification, decentralization, and integration. So as you see, the self-test is in red, as the other ones are in a kind of teal. And that's just to highlight that the self-test is for the screening, whereas the ones in teal are for the confirmation of viremia. Next slide, please. And then just to say that we are doing a great deal of work exploring the feasibility of HCV self-testing. We've completed prospective observational studies in 5 countries using the oral fluid test. And we are now doing those same studies also using the prototype blood, as well as doing an evaluation in the hands of untrained users. And that's going to be in South Africa, Spain, and Georgia. Next slide, please. So to talk about our country studies and projects, this is what we're going to be speaking about today. First, we have Georgia, and Dr. Amaran will be speaking about one of the many projects that we're doing in collaboration with the NCDC in Georgia. This is the point of care molecular testing at harm reduction sites. Then we have India, and in India, we've got 3 projects. So we'll hear from Dr. Ekta from Delhi. Next, we'll hear from Dr. Grover from Punjab. And then we also do have a Manipur study, however, that we won't be covering that today, but we will be covering that in hopefully other presentations. So after India, then we move to Malaysia, and we'll hear from Dr. Radzi about our work in partnership with MOH and DNDi to bring simplified decentralized diagnostics to the Malaysian program. And then we have also Myanmar. And we'll hear from Professor Win Nai speaking about our one-stop shop study that we've done in partnership with Burnett's and Myanmar Liver Foundation. Next, please. So this is just a summary of our project designs, and we don't really have time to get into this now, but it's just to show you the breadth and scope of the work. You know, anywhere from 633 people screened up to almost 39,000 people. So you can see there's a variety of different confirmation mechanisms, as well as treatment locations and etc. Next slide, please. So yes, I'd just like to say thank you to everybody, to all of our partners and all of our participants who have made Head Start a success. You know, we've come quite a long way, and I think done quite a lot in the last 3 years. I'd also like to encourage people to put any of your Q&As that you have in our Q&A box, and we will try and answer all those as possible. If we're not able to answer your question in the session, we will follow up and answer you by email if we are able to contact you. So now it is my pleasure to briefly introduce Professor Sean McGum, as well as Jean-Michel, who will speak after Professor Sean McGum. So Professor Sean McGum is the Executive Board Member of Southeast Asia World Hepatitis Alliance. He is the founding trustee of the Chennai Liver Foundation. He has performed India's first liver transplant in any government institute and the second one in the country in 1996. Following Professor Sean McGum will be Jean-Michel. Jean-Michel has over 25 years of experience in the nonprofit sector, mostly with MSF, and now has been the director of DNDi Southeast Asia for 4 years. He is an advocate for access and public health, and he considers health a public good. So thank you very much, and now it's my pleasure to turn it over to Professor Sean McGum.
Oh, thank you very much for your nice introduction. I have retired long ago, but I have been doing this service of prevention of hepatitis B and C because many of my family members have suffered, and I have taken interest in this, and I have been doing it for the last nearly about 20 years. Yet to continue. My son has become a hepatologist and a liver transplant surgeon. He will join me, and he is carrying out the mantle following me. So we are fully actively doing this in this part of India, and I'm very happy to be participating in this webinar to just share what we are planning to do and what we are yet to do. Next slide, please. As you all know, this is a very major killer disease, much more than HIV and tuberculosis. It is increasing. Hepatitis B is increasing day by day, and the death rate also is increasing. We are losing hepatitis C and B, about 1.5 million per year, death alone. This is really alarming. And we are not very serious about this because it is a slow killer disease. It is not going to kill like a coronavirus or a COVID virus. And then we have to get to read about it. People are very slowly, this disease develops, and then takes about 15 to 20 years, 30 years to develop a cirrhosis liver or hepatocellular carcinoma. And that is the reason people are not giving importance to this, those who are in the helm of affairs of the administration. Next slide, please. Our aim, the impact of target of elimination is about to reduce this hepatitis B and C by 2030 by 90%. That is our aim. We have achieved in 2020 30%. In 25 another 30% we are expecting, and 30 90%. It's a good, if we achieve it, it's the biggest achievement I can say. And so also we will have to reduce the death rate by giving effective treatment, identifying, testing, tracing, and giving the treatment. Very good treatment have come for hepatitis C for the last few years, and it's a good thing. The pharmaceutical companies are able to do it, and we are able to get the cheaper medicines. Generic drugs are being manufactured in India, and we are able to cure many patients hepatitis C. So there's a bright light seen in front of us, and we will be able to reduce the death rate by 2030. Next slide. And the United Nations Sustainable Development Goal, adopted by all countries in 2015, called for combating viral hepatitis with an aim to eliminate viral hepatitis by 2030. That is the sole aim of all organizations in the world. And the United Nations health coverage also has been adopted and this same line. Next slide, please. One of the problems of identifying this disease are 9 out of 10 people are going with the virus in their body without knowing that they have it. That is the whole problem. Unless we go for testing, we will not be able to identify these people. And that is why we have coined the term of finding missing millions. It is very, very important, and that can be done only by tracing the people, testing them, testing everyone individually. Then we can find out majority of the people and prevent the major complications and prevent the death also. Next slide. Barriers, of course, everybody knows that. We got a lack of public knowledge, unfortunately, lack of knowledge amongst the medical professionals. That is, I have been telling you every time. When we were students, we were never taught about the hepatitis B or C. Now, we will have to inculcate the syllabus in the medical school that everybody should learn the seriousness of this problem, and when they come to practice, they should be able to carry out the essential things. Lack of accessibility, the transport systems, the stigma. Once they come to know that they have this problem, probably this social stigma is there, that they're scared about the treatment, and they don't come up out of the stigma. And we'll have to encourage that people should know that it is curable and they can be treated well. Of course, the cost is very important. The government, the NGOs, all the philanthropies should join together, and then we should be able to carry out more number of testing. Next slide. Next slide, please. This is the our organization, what we have been doing for the last. Can I go back to that slide? Can I go back to the previous slide? We have been conducting walkathon. No. The next slide. Next slide, please. Yes. Just keep it. The photographs, please keep it. Photograph the previous slide. Previous slide, please. Yes. We go to the colleges, we go to the schools, we go to the society for a walkathon, and then we go to the various villages, conduct camps. We have conducted about 120 camps in the last 5 years, and we have screened about 30,000 people and for hepatitis B and C, and majority of them under fault of our treatment. This is our organization doing routinely every week by week we do that. Next slide, please. Next slide. Elimination by 2030, what it will take? It takes our energy, commitment, and resources. Energy, we should be enthusiastic, we should be energetic, we should be continuously thinking about it. This is and we'll have to have a public health approach with integrated with the government organization, private organization, so on. And so many people have to take part. Partnership with the government, civil society, we'll have to spread the knowledge left and right so that everybody joins together and the concrete outcome will be there. Next slide, please. Next slide. Yes, if we all join together and find the missing people with the hepatitis B and C, we can eliminate the disease by 2030 with more effective manner as we are fighting at the COVID virus. In this, there is a setback for all these hepatitis B and C screening and treatment. There is a setback temporarily, I hope so. But if we all join together, put our heads together, we will be able to achieve what we are planning to achieve. Thank you very much.
All right, good afternoon from Kuala Lumpur, Malaysia. So my name is Jean-Michel. I'm the director for DNDi for Southeast Asia, and we have been involved with FINE on hepatitis C project in Malaysia. So next slide, please. So DNDi is an organization that is a non-for-profit, same as FINE. We are a collaborative organization, and we focus on neglected tropical diseases. And in 2015, our board has actually decided to broaden the scope of our work to focus on neglected patients. So basically, we use the DNDi model, the collaborative non-for-profit model of development of new treatment, and applied it to not just neglected tropical diseases, but other areas. And for us, hepatitis C was an interesting area because if we want to eliminate hepatitis C by 2030, we do need to have affordable treatment. And at the time we started getting involved in Hep C, there was no affordable treatment. Treatments were costing around $65,000, and that is way too expensive to implement a public health strategy that would drive elimination of hepatitis C. So we got involved. We decided to try whether our collaborative model or open source model, if you want, could be useful in an area like hepatitis C. So we have here the three pillar of our strategy. So definitely R&D, accelerate R&D for affordable treatment for hepatitis C. So R&D is the core of our activity, but we also wanted to work on access issues. So that involves supporting affordable access to all DAAs, not just to the treatment we were developing, but to all the DAAs available, to make sure they would be available at an affordable price across the world. And the last thing we wanted to do on this strategy was to really look at treatment strategies with the objective of simplifying them so that we could scale up treatment. Next. So as I mentioned, this was a little bit unusual for DNDi to get involved in hepatitis C because it's not a neglected disease. There is a lot of R&D, but that R&D doesn't translate into access. The innovation in hepatitis C did not translate into access. So we decided to get involved with the Ministry of Health of Malaysia to bring the cost of treatment down. So we had this, and we still have this clinical trial to prove the efficacy of a new combination, the sofosbuvir and ravidasvir. Ravidasvir is a new molecule that we developed. And we also wanted to expand that collaboration because I think in terms of what we have learned in Malaysia and what can be replicated and useful in other countries is that if we had stick to our clinical trial, we would never have been successful. And what we did was we started with the clinical trial in Malaysia, but over the years, the clinical trial became less relevant because we brought in notions of access, local production. We challenged the patent environment in Malaysia. So all these aspects of an access strategies are important if we want to be able to change the environment for access on hepatitis C. And one of the important aspects is, of course, screening. It was not obvious at the beginning. To be fair, when we started our work with FINE in Malaysia, there was a lot of question about whether it was useful because Malaysia is actually the only middle-income country where FINE had this test and screen, test and treat program. And you wonder how useful it is in a country like Malaysia, middle-income country, where the health system is very strong, as we just saw now with the COVID-19 response. Malaysia has done an extraordinary response to the COVID-19, thanks to its public health system, thanks to the investment it has made along the years in its hospital, in its doctors and nurses and specialists. So there was a lot of doubt about us starting such collaboration in Malaysia. But I think if we look back, it's actually been extremely successful. So first of all, because it added the dimension, the screening dimension, the diagnostic dimension to a project which for the DNDi was beyond and above a clinical trial. Because there was this very practical aspect of how do we bring treatment to people? How do we scale up? How do we decentralize? How do we learn from other work on HIV to make sure that hepatitis C treatment are available at all levels of the public health system? So that was interesting to bring the diagnostic. And today, let's remember that the cost of diagnostic remain one of the main barriers for access to treatment on hepatitis C. Whereas we have seen that the cost of treatment, at least on paper, has gone down. These prices are not necessarily available everywhere, but we know that we can go to around less than $100 for 12 weeks treatment for hepatitis C. So we need to fight to make sure that these prices are available everywhere, but at least we know the price can be low. In terms of diagnostic, we still have the issues of confirmation tests, which are a bit expensive. So there is still a lot to do on diagnostic. When we started with FIND, the collaboration with FIND, I think the impact of that collaboration was really that despite the doubts that were at the beginning, that by working on a test and treat, we actually got the whole of the Ministry of Health motivated and involved. We created ownership and ownership in the transformation of a strategy, in the implementation of a new treatment protocol or screening protocol. Ownership is very important. And I think that's what we did by working with the primary healthcare clinics, by bringing evidence together with FIND that test and treats work, or by highlighting where the issues were. This, I believe, is why in the end, this collaboration with FIND proved extremely successful and extremely important in changing treatment options in Malaysia. There was a real effort and a real push to decentralize, and even though the leadership of the Ministry of Health was in favor of decentralization, bringing the evidence, we will never repeat that, I think, enough, bringing the evidence that it works, that it is possible, is key in changing strategies. And that's what we have done with FIND in Malaysia. And I think that was, and the Ministry of Health, of course. And I think that was very important, because we see there is a real motivation to bring treatment at a community level. And that's the only way we can eliminate hepatitis C. So I think that's it for me. There is a time for questions, but I will stop here. Thank you.
Hello, good morning, afternoon, and evening, everybody. My name is Philippa Easterbrook from the Global Hepatitis Program, and I'm delighted to be moderating the remainder of this webinar. As Sanyal has already outlined, to achieve the goals of elimination, we need to have a radical simplification of the care pathway for hepatitis C. And demonstration projects and implementation science are an important part of generating the evidence base to inform WHO guidelines and shape the development of national policy, and identifying what innovative approaches can help simplify service delivery. So you'll be hearing from 5 such projects, all with some common questions, but applied to the distinct healthcare infrastructures in 4 different countries. And this is the culmination of 3 years of work led by FIND in collaboration with many partners. So it's a real celebration of the power of partnerships and the excellent work of the country teams at the front line in delivering these projects to a successful conclusion. Also a thank you to Unitaid, who supported this program of work with FIND, and prior to that with MSF and continuing support to Coalition Plus. And they're to be congratulated for their vision in prioritizing this area for funding. For WHO and the Global Hepatitis Program, this has been a very close and important partnership at every step of the way, from planning and protocol development, project implementation, monitoring and evaluation, and analysis, with many joint missions. And this has been a great privilege to be part of this collaboration from start to finish. So I would now like to move on to the introduction of the first speaker of the projects, and this is Dr. Radzi, who's the National Head of Gastroenterology and Hepatology Services at the Ministry of Health Malaysia. He's also Head of Clinical Research Center at the Hospital Sultan Al Baiyar. So Dr. Radzi, a pleasure, and to hear the results from the Malaysia project. Thank you.
Thank you, Philippa. Well, first and foremost, I would like to thank the organizer for inviting me to share the experience of Head Start project in Malaysia. Indeed, it is a privilege to be part of this project, and it's a very unique work that we have done, because the main reasons why I think what I would like to share with all of you is that it's a success, and it's also proven on how the collaborations with the various organizations, Ministry of Health of Malaysia, together with the FIND and also DNDi, who have been working very hard in order to make it the effort towards eliminations of hepatitis C a reality in Malaysia. Okay, next slide, please. Okay, as like in other projects, the key principle in this project is how to simplify, decentralize, and also the integrations to make it or to drive the HCV eliminations to be a success. So this is the same principle that we use and tailor towards Malaysia. So we have done the study at a few states in Malaysia, and with the collaborations of all the organizations that I mentioned just now, we have successfully executed the project, and I would like to present the finding, or the main finding, in the interest of time. Next slide, please. Okay, so what we have found, I mean, out of 2,000 patients to be identified, to be confirmed based on RTT positive, out of 15,000 that have been screened, 75% of them have received confirmatory testing, i.e. the viremia status. And out of that also, 75, 3/4 of them have received the treatment. So this is a tremendous achievement. I mean, because we all know that we have lots of problems, despite of all the resources and also the infrastructures that we have. We are not able to come up with a higher percentage of link to treatments. I wish it could be close to 100%, but we have some problems. But I'm glad that even up to now, we can see that there are huge impact of this project in terms of our practice, and also in terms of determining the directions of how are we going to do the elimination strategy in Malaysia towards eliminating virus by 2030. And one of the main highlight here, which I can share with you, is that it has certainly cost it has certainly reduced the cost. I mean, we're talking about the risk-based screening versus the general screening, while it has reduced the cost from the more than $40 to less than $7. Okay, next slide, please. So, in conclusions, I mean, what we have learned from this Head Start project in Malaysia. One thing for sure, the major impact which I would like to share with all of you is that it has proven beyond doubt that this is the way how to go. I mean, we need to simplify, we need to decentralize, and also we need to integrate all the services relevant to the hepatitis C. And so that's the way it should be. And it has been proven to be doable. And as a result of that, also the impact of this project, the Ministry of Health of Malaysia has already embraced and also adopted the strategy is simplification, decentralization, and also integration. And starting from end of last year and also the beginning of this year, we have already started to decentralize our care for the hepatitis C throughout the country. In fact, all the healthcare facilities in Malaysia has already started the test and treat for the hepatitis C. And we also have extended this model to the other institutions as well, i.e. The prisons, as well as the cure and care rehabilitation center. So it's going to be very interesting, because I can see that the uptake for the test and treat is tremendous this year, because we are actually in the best position right now. We have a very strong political will from the government of Malaysia, a very strong support from Ministry of Health, and also we're working very closely with the DNDi, FINE, and also the CSO all together. So I'm very, very positive that what we have done in the Head Start project will be realized in what we're going to implement our treatment for hepatitis C in Malaysia. So with that, I thank you.
Thank you. Thank you so much, Dr. Radzi, for that sort of excellent summary. And I'm aware that you have to leave shortly, so I am going to ask the question that was otherwise going to be in the panel discussion. My question is, it's very encouraging to see this fast tracking of decentralization and the project being a key catalyst for this. And you've just outlined at the end of your talk the plans for this. There are many advantages of decentralization, but perhaps you could just outline what you consider the key challenges to decentralization of the care and treatment, and what are they, and what are your proposed strategies to address these? For example, training of the healthcare workers. Over. Thank you.
Yeah, well, of course, there are always challenges ahead. But one of the things which I would like to share among the challenges which I have faced before will be how to align the expectations from the various sector or various divisions in this. Because, for example, like we're talking about not just the healthcare provider alone, but we're also talking about the lab support. We're talking about the pharmaceutical. I mean, the available, the procurements of the treatments, and also on the other hand, some of our clients, which is probably not in the same fraternity, i.e. not under the Ministry of Health. They are from a different ministry. For example, like cure and care, they are on a different ministry. So these are among the so-called how to align them, so that everybody aware and everybody knows that we have the ways and we have the platform on how that we can work together, and then we can actually deliver the test and treat at every level. So there's no shortcut in this. I think the best things actually we have to keep on collaborating, keep on educating, and also talking to each other and trying to find the best way. As I mentioned, I think Malaysia stands in a very good positions at the moment because we have all the supports from all the major stakeholders in the country. So we can talk to the other ministry, we can talk to the other divisions quite easily. There will be some problems initially, but at the end, we will find a common pathway altogether.
Thank you so much. I think I will just ask one final question before moving on to the next presentation is, what do you feel were the most important levers to pull to persuade government to move as fast as you've been able to move?
Well, yeah, I must say that I must admit that I'm probably not the best person to answer this thing, because I'm living in an environment whereby I'm having a very good support from the leaders, from my Director General, Ministry of Health, and also the good strong political will. But I think the best strategy is actually to make them understand. Keep on persevering, talking to them, so that I think at the end of the day, with all the strength that we have, i.e. that we have the drug that cure, and also we have all those effort that we have done, reducing the cost, so on and so forth. I'm sure they will buy it.
Thank you so much, Dr. Radzi, and for taking part in this, this webinar. We're now going to move to the next presentation by Professor Liang, who's head of the hepatology unit at the Yangon Specialty Hospital and has played a critical role in advancing the Hep C care and treatment agenda in Myanmar. Over to you, Professor Liang.
Thank you. Actually, I'm going to present my two study. This is a community testing and community treatment study, which was supported by Barnett Institute in our country. Actually, our country has a population approximately 53 million and estimated hepatitis C antibody positivity about 2.7 among the other population, and higher at 56% among the people who inject drugs. Next slide. Next slide, please. Over 1.4 million people living with the hepatitis C infection in our country. And the program was implemented in 7 specialty hospitals to start with at the liver units and ART specialty hospitals. The national guidelines allow the general practitioners to treat hepatitis C infection with a pan-genotypic regimes, only referring to the specialist when the patients present with physical signs of decompensation. The CT2 study was designed to better understand the feasibility and effectiveness of a fully decentralized service delivery model at lower level healthcare facilities with a focus on reaching key populations. Next slide, please. So we implemented a fully decentralized one-stop shop model of a care using point of care hepatitis C RNA testing using a gene expert platform on site at the study sites and trained general population, general practitioners, initiating patients on the treatment. With the hepatologist available for a review of patient requiring specialist review at a local tertiary hospital or through the rotating specialist at the clinic on the weekends. So we had 2 study sites in Yangon, Barnett Institute Clinic, and another one is Myanmar Liver Foundation, Transit Charity Clinic. So next slide, please. Yes, here is our cascade of care across the both sides. You can see really good retention in care of antibody testing to RNA testing, and then studying on the treatment. Of course, those studying on treatment, majority of the participants completed the treatment. And then we achieved a sustained virological response about 93%. So just to note that majority of the Barnett Clinic participants reported injecting drug abuse in the past 6 months and were currently on the methadone. And our results were similar across both sides. Next slide, please. So you can see this is a turnaround time from RNA test to DNA prescription. So most of the patients have turnaround time from RNA test to studying onto the treatment, including any specialist review was short at both sides. You can see only 4 days for the Barnett Clinic and a median of about 2 days. Next slide, please. So mode of care is feasible and safe and effective. It is possible to implement at our national strategy plan site and the clinic sites to fit the clinical requirements. So retention of care is exceptional. In particular, through the diagnostic pathway and onto the treatment. They are similar among the people with injection drug abuse as well as the general population. And our sustained biological response rate is very good and similar across the both sides. So there are evidence of model of care implementation in Myanmar. And then this is a very good model, and then we achieve very good sustained biological response. So we are planning to expansion of these services to other sites and other structures. So thank you very much. Next slide, please. So I'd like to acknowledge our CDU team, our main investigator, Professor Margaret Hallat, as well as Dr. Lati, and our co-principal investigator, Professor Wu Winsui, Dr. Ken Sandaong, and Professor Mama Kim Dongchi, and other partner teams, MLF clinic teams, fine staff, and then all our participants. Thank you very much to complete our study. Thank you for my presentation. I'm very happy to listen any comments and answer to any questions. Thank you.
Thank you so much, Professor Nang. We will leave the questions till the end. And I would now like to introduce the next speaker, moving swiftly on now to Georgia. And it gives me great pleasure to produce Dr. Aaron, the Director General of the National Center for Disease Control and Public Health in Georgia, who has held several leading managerial positions in the field of public health in Georgia, and was formerly a Minister of Labour, Health and Social Affairs. Over to you, Dr. Amaran. Thank you.
I would like to welcome the participants of the conference dedicated to the World Hepatitis Day 2020. And I am very grateful to be a participant of this conference, and I will give you a short overview of NCDC and FIND partnership in Georgian HCV elimination program. As you know, and are informed that Georgia started the HCV elimination program in 2015, and since the beginning, with many other partners, FIND is our partner, and I will give you a short overview of what was done in the last 2 years together with FIND. The first slide shows the prevalence of HCV in Georgia. Unfortunately, we are a high prevalence country. The chronic infection is in 5.4% of adult population, which in absolute figures is 150,000 of the population. Leading genotype for Georgia is the genotype 1B, and then comes genotype 3 and genotype 2. We have a picture of from the right side, the distribution of the prevalence of the HCV chronic infection in different regions of Georgia, as well the target, how many people in each region are the subject of the treatment. And the elimination program, or the action plan for the 2015-20 has 3 targets. The 90% of people living with HCV should be diagnosed until end of 2020. 95% of those diagnosed are treated, and 95% of those should be cured. Unfortunately, due to many circumstances, as first of all of the pandemic of the coronavirus, we cannot reach all the targets, but I hope that's the continuation of the program for the next 3 years until end of 2023. We will reach the major our targets in the elimination. The next slide shows that while the national program has strong success in that over 70,000 people have been enrolled in the treatment, the data showed that among key populations, such as people who inject drugs, there was up to 50% loss between rapid diagnostic tests, screening, and viral load tests. Therefore, NCDC and the FIND partnered to conduct a study to understand which diagnostic pathways can be more effective in in facilitating HCV testing among IDEUs. The objective of this study are to determine if the proportion of participants who receive results of HCV viremia testing differs between the arms, characterize the HCV care cascade for IDEUs identified through harm reduction sites in Georgia, and they quantify the proportion that goes through each step in the cascade, and finally to assess the cost of different testing strategies per the arm. The next slide shows the map of the study sites. You can see that there were sites located all throughout the Georgia, and altogether I think it's the 8 sites. The next slide gives us the understanding of non-randomized interventional study at 8 harm reduction sites in Georgia. The next slides shows that the 4 sites conduct blood draw and point of service decentralized HCV RNA testing by using gene expert platforms, and the results are provided at harm reduction sites on the same day. 2 sites collect blood samples on site and transport them to the reference centralized laboratory like the Lugar Center of NCDC for the HCV core antigen testing. Results are provided at a follow-up visit to the harm reduction sites. There are 2 harm reduction sites. One refers anti-HCV positive patients for HCV RNA testing to HCV treatment centers, and the results are sent by SMS to patients. The other one collects blood samples on site and transport them to reference centralized laboratory Lugar Center for HCV core antigen testing. Results are provided at a follow-up visit to harm reduction sites. Here we see that arm 1, where the gene expert was on site, 100% of participants received an RNA test. In arm 2, where the blood was drawn on site at harm reduction sites and sent to Lugar for the confirmatory testing, 99.8% of participants received a confirmatory test. And in the arm 3, where the rapid diagnostic tests plus participants were referred to the treatment centers off-site, 89.8% received confirmatory testing. Next slide shows some summary of our the study impact of national policy. The introduction of decentralized HCV confirmatory testing catalyzed the decentralization of HCV treatment in the harm reduction sites. Blood draw at harm reduction sites and sample referral to Lugar Center now the norm or the standard nationally in harm reduction sites. Provided evidence towards the decision to make all diagnostic free to the patients. These lessons can be helped inform the update strategy plan for HCV elimination for 2021-2025. Thank you very much, and the acknowledgements to all, our partners like FIND, CDC, and WHO, Unitaid, and all others, of course, the Ministry of Health and Harm Reduction Network. Thank you very much.
Thank you so much, Dr. Amaran. So we have heard now from 3 countries, Myanmar, Malaysia, and Georgia, and we now have the next 2 presentations from India. I would like to introduce Dr. Ekta Gupta, who's a professor of virology from the Institute of Liver and Biliary Sciences, which is also a WHO collaborating center based in Delhi, India. And Dr. Ekta Gupta has been the principal investigator of this study. Before beginning the presentation, I just want to remind all the attendees to post your questions. We'd like to encourage as much participation and engagement So questions directed at the presenters. Thank you. Dr. Gupta, please.
Good evening, everyone. And I thank FIND and the other Head Start activity who has given us this wonderful study opportunity to be done in Delhi, India, which is the capital city of India. And I'm Dr. Ekta Gupta, and I'm professor and head of virology at the Institute of Liver and Biliary Sciences, which is the leading liver institute in Delhi. So we started along with as the part of the Head Start activity project, decentralized and simplified HCV care in Delhi. Next slide. Next slide, please. Yeah. So looking at the estimated people who are infected with hepatitis C, there are about 12 to 18 million people who are infected, and that accounts for a significant proportion of global hepatitis C burden. Now, we have already initiated in 2018, the Government of India has already launched the National Viral Hepatitis Control Program. It has been phased out in a very phased manner, and many states have taken it up, but Delhi is yet to start. One of the things that we found was to accelerate the elimination of hepatitis C globally, we have to increase the access of testing services. And that is why the objective of this activity of the Head Start was to decentralize the testing services in a hub and spoke manner. They were initiated in Delhi as a pilot model. Next slide. So under this Head Start activity, there were three arms which we took care. First was that we identified 5 nodal hospitals to which we connected the centralized testing services. Now these 5 hospitals were selected as they contained most of the geographical location of Delhi, as I'll be showing you in the next slide. And they were the sites where we had clinical nodal officers, the lab nodal officers, and most of the patients were coming there, they were tested, and the treatment was offered. Now, each of these 5 hospitals was also connected to 3 polyclinic each, that is 15 polyclinics, where there are patients who are coming with the general ailments, and their footfall is maximum in these small healthcare facility to further decentralize the testing and treatment services to the farthest areas of the Delhi. Then we also conducted few outreach camps to reach out to more and more people so that the testing services can be decentralized and offered to as many people as possible under this project activity. Next slide. As you can see on this map, the sites of hospitals and the polyclinics were identified so as to reach out to the farthest geographical location of Delhi, which is there. And then they were all, the 3 polyclinics were communicating to the hospital. There was the site where RDT was done and the patients were referred to these hospitals. At the hospital, we had a clinical nodal officer. Again, the RDT could be done at the patients coming to these hospitals, and the antibody positive patients were identified. All the blood were collected for confirmatory test and was sent to the centralized lab at ILBS. Within a day, in one day turnaround time, the RNA and the confirmatory report was sent by email to these hospitals as well as to these polyclinics. These were the sites the patients were there. They would come, their primary investigation was done. The treatment was offered at these 5 hospitals. And this was how the various, the cascade of HCV care was conducted during this project activity. We included almost all the adult patients who were coming to the general OPDs in these hospitals, and we excluded, however, children less than 18 years, those who were pregnant and breastfeeding, and the patients with chronic kidney disease. Next slide. So in this small study, the study actually, because of some administrative problem, they actually started that is 786 came out to be HCV antibody positive. So in Delhi, never such general population prevalence of hepatitis C was conducted. So for the first time, we found that the prevalence was about 2%, although it was more from the hospitals. So not representing the true data, but still it was about 2%. We could actually do the confirmatory test on almost nearly 90%. So this was the thing, that by decentralizing these testing services, we could achieve a 90% confirmatory test to be done on these antibody positive. RNA positivity came out to be 86.1%, which showed again that the RDT were picking up good cases, and it was a good point of care of test that was being taken care of. The treatment was initiated in 80%. The only thing was that the SVR was tested in 60%, because most of the patients whose SVR was due in the early months of 2020. And because of this COVID pandemic, we could not, because of the lockdown situation in Delhi, we could not call many of the patients. But however, whatever the SVR test done, we showed 96.3% cured, and a good achievement of treatment success was seen in these 96.3%. Next slide. Now, looking at the two arms when we compared, that is the hospital where the patient's flow was direct, and the polyclinic where the patients came, but then they were referred to these hospitals, a statistically significant drop in the percentage RNA being tested, the treatment initiation and retention of the patients was seen. In the polyclinics where the patients were principally called, tested, and then they were referred to the hospital, we could not retain many patients as compared to the hospitals where they were called, the treatment was also initiated, and the samples were collected there and there only for the confirmation test. There the retention had shown 81.7% as compared to the polyclinics where it is 16.6%. So clearly showing that the retention and treatment initiation can be done if the patients are not being referred to multiple sites, and there is a direct referral, only a single site, which comes out to be the most effective. The prevalence also varied in district hospitals, 3.1% to polyclinics 1.6%. This was clearly because in the general hospitals, you get more sicker patients, while in the polyclinics, which are small healthcare settings and manned by only one medical doctors, you do not get so much sicker patient, and that is why the prevalence rate differed in these two sites. Next slide. So just to conclude that when we started with this hub and spoke model of decentralized HCV care provision at the point of care, it proved out to be very effective, at least at the hospital setting. Now we decentralize the lab services to the peripheral sites, which is an important point, because molecular testing services cannot be started or initiated at these 20, 30 different sites. So connecting the centralized lab to the peripheral sites and via the sample referral compared to the patient travel will really help in a better patient retention, which was clearly seen. And one point referral system to be adopted rather than referring the patient from one side to the other to retain more and more patients in the cascade of care. Now, this initial pilot study in Delhi, where no such study has done and where we are still going to unfold the National Viral Hepatitis Control Program through the Government of India, it paves the way to create how to eliminate HCV through primary health care and point of care with existing resources in public health settings. The results can be very, very helpful in guiding policies for increasing the uptake of testing at a larger scale, and which we have done. We have shown this data, and the Delhi government is very keen. Because of this lockdown situation, it is slightly delayed, but in next few months, we will come up and we will utilize these sites and polyclinics to actually start the National Viral Hepatitis Control Program in Delhi in this manner, as the way we have shown through this Head Start activity. Next slide. Next slide. Yeah, so in the end, I would like to acknowledge our director, Professor S.K. Serene, who could not join because of his prior commitments, who has given us a green signal to conduct this kind of a pilot study. Our Director General Health Services, Dr. Sandeep Miglani, all the nodal officers from different hospitals, data entry operator, technical staff, and all the entire team who worked with me in the Department of Clinical Virology at ILBS. Nevertheless, fine Delhi office, Chai Foundation, WHO India, Global Hepatitis Program, National Viral Hepatitis Control Program, and Unitaid for funding and extending the support to carry out this pilot study in Delhi, one of its kind, by which we can really guide the National Hepatitis Control Program in our country, and especially in Delhi. Thank you so much.
Thank you so much, Dr. Gupta. We're now going to move swiftly on to the next presentation because we're now running several minutes behind. And it gives me great pleasure to introduce Dr. Gangajeet Grover, who's the State Nodal Officer for the National Hepatitis Control Program in Punjab, India. And Dr. Grover really has been a major driver of the Hepatitis C program in the state of Punjab, which started in 2016. Dr. Grover, thank you.
Thank you, Philippa, for the nice introduction. And I'm thankful to find WHA and all the DNDi and all the organizers for organizing this beautiful webinar. And as you already said, we started in 2016. And can I have the next slide, please? When we wanted to expand the program and we were looking for a partner and find they were help and support to us and made a very good partner we found in FIND, and we started a project in 2017, the project Head Start, wherein we started screening of all the PLHIVs in the ART centers in Punjab. That was the first of its kind in country, where a massive scale at all the ART sites were covered and PLHIVs were selected. And apart from that, I'd like to tell you, Philippa, this project is still, we are closing it down. The screening has stopped and we are now correlating all the data. We had a MOU with FIND for another project for screening of all the prison inmates that was signed in 2019, which we'll be glad to share in the coming webinars and sessions. Next slide, please. Punjab, if I just talk about the demography, we have 22 districts and a population of around 27.7 million. That was 2011 census. In 22 districts, we have 13 ART centers which were linked with 4 sites which had gene expert machine. So all the samples, they were tested with RDTs with support of FIND, LTs, had by FIND at 13 sites, and samples for viral load testing, they were sent to these 4 gene expert sites where viral load testing was done, and the results were referred back. So it was a hub and spoke model for us where the patients, they didn't have to travel, only the samples were traveling. If briefly, in Punjab's prevalence is still coming out, we have to exactly confirm that, but from various studies, it's around 3 to 3.3%. However, with our data from this project Head Start, the prevalence is coming out to be around 20% in PLHIVs. Next slide, please. If we look at almost 27,000 PLHIVs were screened, and out of those 20.4%, they were positive, and reflex testing were done. If we look the screening, the majority males with 63% and around 37% for females. But out of when RDTs were done, the HCV positivity is in almost 89% of the males and 11% are females. Next. If we look at the screening and the RDT positivity data of among the 27,000 PLHIV screened, majority are in the younger age group from 21 to 50, and the RDT positivity is much higher in 21 to 30 age group, which is a matter of concern, which has given us a new scope of work that this younger population is being affected with co-infection, and we have to work on that. Next. If you look at, I'm comparing 2 cascades, Philippa, here. One is the Punjab from 2016 to June, where we have screened 160,000 in-male patients in Punjab, and 85,000 they have been put on treatment. Almost 70,000 they have completed. 67,000 are eligible, and 52,000 SVR done, and cured around, SVR achieved around 48,000 plus, and that gives 93% of the data. If I look at ART center cascade, we screened 27,000 PLHIVs, screening positive are 5,000 plus, which is around more than 24.4%. Viral load positive are 4,400, 2,300 they have started on treatment. 2,100 they are pending for treatment because of lockdown. They were all screened in last phase of December and January, and they were supposed to be put on treatment. Now, since the lockdown is over and we have started functioning ART centers, now all these patients, all PLHIVs are being put on treatment. And the results, they are still evolving under this, and this is an ongoing process, and within few days we'll have the outcomes. Next, please. So if I conclude, this helped us to integrate HCV testing with ART clinics, and we were able to screen the HCV among PLHIVs, and we were able to do reflex testing by linkaging all the RDT positive viral load with the treatment, and care cascade that has helped us to linkage between separate programs within AIDS Control Society, viral hepatitis, and other programs and harm reductions. And this will help us in increasing our treatment initiation rates, and as the results are increasing, we'll put all the patients on treatment. Next, please. Next slide, please. So I'll thank all the ART staff who worked diligently and all the LTs who worked for this thing. WHO for our guidance, Viral Hepatitis Control and Government of Punjab for supporting us in providing the drugs. And over and above all, I'm thankful to Dr. Sanjay Sareen Sonil and all the fine team, Dr. Preeti, Navneet. They worked so hard, and now we have come up with this project is complete and with wonderful results that helped us. Thank you very much.
Thank you so much, Dr. Grover. And I know you have to leave. Perhaps I can just ask one brief question before passing over to Sonyel. There have been some, there's been a huge success, although still, I think, with the COVID effect that you're sort of responding to in terms of the SVR. What do you see as the main sort of do's and don'ts as you scale up to other ART clinics across Punjab and beyond? And also the positioning of the point of care viral load, which was part of this study, going forward, how will that fit into the Punjab program? Over.
Thank you, Philippa. Philippa, these are all ART centers, 13 ART centers we have, and we have covered all of them. With Head Start, we covered around 27,000 PLHIVs, and the remaining PLHIVs who have been enrolled, they are being taken up under the government program. We have taken over the project, and all the persons, they are being put on treatment. And with this experience, we know that it's around 20% that gave us a big information or the insight that we have to go for the harm reduction a lot, and behavior change and community participation will be very important if we have to deal and go for hepatitis C elimination in Punjab. As we'll be scaling up to now OST centers after ARTs, the challenge will be much bigger, as they will be dealing directly with the IVDUs where the prevalence is expected to be much higher than this. So this project Head Start has given us a very good platform to let me, my government, and all the policymakers in Punjab to know that this could be the quantum and this could be the problem which we are going to face and we have to face.
Thank you so much. And over to Sonyel.
Great. Thank you very much, Philippa. And thank you very much, Dr. Grover. That was a really excellent presentation. I'd like to thank all of our speakers so far. And so we're running a little bit behind. So I would like to leave at least 15 minutes for questions for the Q&A session, because I think oftentimes that's the most interesting part of these webinars. But I just wanted to briefly say that we have compiled a list of resources on our website, various hepatitis resources. And some of them come from FIND, some of them come from TAG or CHI or Global Hepatitis Task Force. So they're not all FIND resources, but we just think that they are useful to people who are working to scale up and advance hepatitis C service delivery in their context. So that leaves us 15 minutes for questions. So I will turn it back over to Philippa and the rest of the panel. Thank you.
Thank you, Sonyel. So in the 15 minutes we have available, I think we are still waiting for questions to come in from the attendees. But what I'd like to do is to start with Dr. Gupta. I have a number of just targeted questions while we are waiting for others to post their questions. So Dr. Gupta, in terms of implications for policy, there was a lowish yield and linkage to care for those in polyclinics, but a very high yield and linkage in the hospitals. What are your views in terms of scale up in Delhi and beyond on the relative prioritization of polyclinics and scale up, and how we can optimize testing in hospitals where inevitably there will often be a higher yield? Thank you.
Okay, thank you, Dr. Philippa. It was a very interesting observation and a good question, because we also felt there were too many reasons to why the polyclinic linkage to care was very less. First thing was the manpower support given to these polyclinics was given at, was not given from the very beginning. It was more in the hospitals which we gave. And then we realized that it is very difficult to mobilize patients even who are very near to the hospital. So the polyclinics were chosen that they were within the vicinity of 5 to 10 kilometers of that hospital. Still, the patients were reluctant to reach to these hospitals and get their blood collected for a confirmatory test. And when we realized, we supplemented the manpower to these polyclinics, but still the data reflected that we could not motivate more patients. So one thing which we learned, and which is a lesson for the national viral hepatitis, and we are going to communicate to the government of India, is that wherever a person comes, it is very difficult to mobilize these patients from one side to the other side. And that is why the decentralization of testing services, either in the way of providing the point of care of testing to those sites where the patient is there, and not losing on a single day and immediately collecting the blood for a confirmatory test, is the most important. The more delay is there, either in referral or in collecting the blood sample for an RNA test, you will miss out to the patient. And you really need a very strong commitment from the healthcare settings to catch these patients and find and come and make them come to the get an RNA test. So that was the reason why there was a disparity, and which is reflected onto our data from the polyclinic and the hospital. And we are definitely going to find out these lacunae, and whatever shortcomings we had, we are going to propose to the government of Delhi when they are going to initiate the testing under the National Viral Hepatitis Program.
Thank you, Dr. Gupta. Moving swiftly to Dr. Amaran, who is also online with the Deputy Director General, Dr. Irma. The question is, the gene expert certainly helped with uptake of the viral load confirmation, but the time to treatment was still quite long. What steps have been taken to sort of generally speed up time to treatment? And what do you consider going forward to be the optimal use of the point of care viral load to promote access in Georgia? Thank you. Dr. Amaran, did you hear my question? In which case, perhaps while Dr. is coming online, I am going to move on to the next question to Professor Naing from Myanmar. There really was a very impressive linkage right across the cascade of care. So it's really shown the feasibility and the effectiveness of this one-stop shop. I'm aware you're already providing treatment at ARV clinics. What other settings and opportunities in Myanmar are there for this one-stop shop? Can this model be applied to other harm reduction sites also? Thank you.
Thank you, Philippa. Yes, I agree with you. Actually, we have good services and good communication. And then our consultants from the both sides have a very enthusiastic, and they give a lot of consultation times. So most of the patients believe they are doing the right treatment, and they have a good opportunity to get cleared from hepatitis C infection. So our one-stop shop service is very effective, and then it is very good response. So I think it can be used in other sites, for example, harm reduction sites, needles, syringe sharing center, etc. So our government are concerned about this community testing and the community treatment model to implement in our national strategic plan, and then we are considering to use these models in many district area, especially difficult to get access to the store and services. So I think it is a very good model, and then we think of one-stop shop service model in the future to clear the hepatitis C infection, to eliminate hepatitis C infection in our country. Thank you very much.
Thank you very much. We just have a few more minutes left for questions, 4 minutes. And so I would just ask the panelists to be very brief in your responses. And I'd now just like to ask a further follow-up question from the audience to Dr. Grover. And this was about what is going to be your approach for retreatment? How many of those who failed treatment have or will be retreated, and what will the protocol be? Over to you, Dr. Grover, again, brief responses. Thank you.
Hi, Philippa. I just read that message. There are 3,500 patients who have failed. They're already being linked with all the model treatment centers at PGI into medical colleges, where they will be further investigated and will be put on treatment by the government. So all these patients are being tracked, called, and being put on treatment.
What will the treatment protocol be? Is that as part of the national guidelines?
Yes, exactly. We'll be dealing with the national guidelines. It will be soft decla we are already giving, and for the failure, it will be used soft-well, and if the patient are, then soft-well and revive. It will be the national protocol.
Thank you. And a quick follow-up question to Dr. Gupta. Again, just a brief response. Question from the audience. Would it be possible to take the blood sample at the polyclinic and transport it to the labs rather than requiring the patient to go to the ILBS? Is this planned for a next phase? Thank you.
Yeah, thank you, Philippa. Yes, this is a lesson we have learned, and we are going to implement in our when we are going to roll out the National Viral Hepatitis Program. We will collect the blood for the confirmatory test at the site where the patient has first visited and an RDT test has been done. Yes, this is the plan we are going to do in our rolling out of the National State Viral Hepatitis Control Program. Thank you.
Thank you. And I'm now returning to Dr. Amaran. Can I ask if you would like me to repeat my question, or whether you heard this first time round?
Hopefully you can hear me now.
Yes, Emma.
Okay,
thank you.
Thank you. No need to repeat the question. And first of all, thank you for Dr. Filippo for this opportunity. Yeah, so that's during this entire implementation period of hepatitis C program. So there have been a number of steps undertaken to shorten time, which was needed for treatment enrollment after the confirmation of diagnosis. So it was centralized, and at some point it became electronic with limited days given to committee member to assign people. However, so there is one logistical problem remains. So after inclusion of patients in a certain location, so drug distribution follows. So this is one of the reasons that still we are facing in general, not related to harm reduction centers. So quite a long time period, so which is in mean months or so after confirmation to inclusion. In case of the Head Start program, so which, as it was mentioned by Dr. Amiran in his presentation, so this program catalyzed decentralization of the treatment at harm reduction sites. However, so this process, I mean, they followed and we start the program. So that's with the different modalities of diagnosis, and this decentralization of the treatment came later on, and we have just 10 patients at the end of program included on a treatment and harm reduction side. So right now we don't have enough evidence to analyze what was the impact of the treatment initiation at the harm reduction at this decentralized sites. So I think the further study will be needed to in order to analyze and evaluate impact, and we are looking for discussing, and we are looking for our technical partners as well to discuss this issue and design some probably small study to evaluate this impact. Thank you.
Thank you so much, Irma. And I'm going to defer my question to Jean-Michel until the end of the next session. So I would now like to move swiftly on to the next part of the program, which is really on community awareness and mobilization. And they've been extremely important partners in supporting this fine project. So I'd like to introduce the first speaker is Bringay of the Hepatitis C Virus Project, who's director at the Treatment Action Group based in New York. For those of you not aware, TAG is an independent activist, community-based research and policy think tank that works in both HIV, TB and hepatitis C, so able to draw on the many synergies in community work. Bryn, thank you.
Thank you for the introduction. I hope you can hear me. My presentation is on strengthening diagnostics literacy and meaningfully engaging affected communities. It's really a pleasure to virtually meet with everyone today from around the world and to highlight the community engagement and diagnostics literacy work that we've been supporting in the Head Start project. Next slide, please. So I'm putting my takeaways and disclosures up front. And among these are 3 takeaway points that I'd like to focus on. First, community-centered approaches and peer-driven responses can increase diagnostics and treatment uptake. You'll also understand the importance of community monitoring of the Hep C care cascade. To this point, meaningful community participation in the design of these studies, treatment and diagnostic scale-up, and implementation provides more precise strategies that meet the needs of patients, such as addressing medical provider bias and creating community-friendly clinics. Community participation recognizes that community leaders should serve on national steering committees for guidelines and national strategy development. Community participation should be tailored for each context. It needs to consider local languages and different affected communities. Community participation also requires support for more treatment and diagnostics literacy and training for community leaders and civil society organization staff. So the benefits of community engagement are clear. It builds relationships and trust with health authorities. It debunks myths about viral hepatitis in stigmatized communities and can help leverage community engagement for the Global Fund, other donor planning, or national budgeting. Thirdly, this part of the project may have wrapped up, but the advocacy work isn't over, and we need to resource communities with a budget for advocacy and coordination. This requires funding advocacy and fairly remunerating peer workers to help navigate patients through the care continuum. These are our partnerships currently this year. Next slide, please. So community engagement is grounded in principles of nothing about us without us, empowerment, and the Denver principles, which are just as relevant for viral hepatitis and for all key populations. Next slide, please. So in this work, TAG created a number of diagnostics literacy materials that were developed and tailored for workshops in Georgia and Malaysia, and also shared for community workshops in India. It's important to note that most participants had little to no knowledge about Hep C diagnostics beforehand, and many were more familiar and had more in-depth knowledge about treatments stemming from years of AIDS activism. Workshops in both Georgia and Malaysia aimed at strengthening knowledge of treatment advocates on all things hepatitis C and harm reduction, to debunk myths and develop community-led strategies to overcome diagnostics barriers. In Georgia, FIND and TAG partnered with the Georgian Harm Reduction Network and Georgia Community Advisory Board to conduct 2 key advocacy meetings and to spark community engagement with the Ministry of Health, the NCDC, and other health authorities involved in the technical advisory group and national elimination process. So you see over here some of the participants who are medical providers, harm reductionists, people with lived experience, and community leaders from different key populations and from different regions. I'd like to highlight that there were 4 working groups that came up with community-led strategies to overcome diagnostics barriers. They were to increase hepatitis B and C screening in the community through decentralization, to integrate hepatitis B vaccination in low threshold harm reduction settings, to create public awareness campaigns and capacity building about hepatitis C, and to plan activities aimed at high-level national policy reforms. Some of the follow-up that was included after the workshop was the development of community recommendations and the integration of viral hepatitis and messaging and HIV campaigns. Next slide, please. In Malaysia, FIND and TAG partnered with the Positive Malaysian Treatment Access and Advocacy Group, MTAG. And you see here our speakers and participants who are family medicine specialists, the Malaysian AIDS Council, DNDi, Third World Network, people with lived experience, and community leaders from key populations that were different from Georgia and from across different states. We conducted 2 key advocacy meetings as well to prepare community leaders to participate at the 4th National Hepatitis Conference. And this was the first time community was invited. It was also to reinforce community engagement with the Ministry of Health, as well as the inclusion of representatives on the National Hepatitis Task Force. The next speaker will provide a more in-depth look at the advocacy gains, but I wanted to highlight the community-led strategies. You'll see the blue matrix on this slide as one example. The 4 strategies were to increase awareness among people at risk or key populations, to encourage them to go for testing, to increase decentralization of Hep C health services, to collect more comprehensive Hep C specific data, and to strengthen and escalate advocacy for treatment availability. Some of the follow-up included creating a CSO wish list, and notably, there's been the inclusion of one participant who is a Global Fund country coordinating mechanism representative to serve on a World Health Organization technical working group on Hep C and substance user health, and this informs global policies. Next slide, please. So now I will walk through some of our literacy and advocacy materials. The workshop provided feedback and key questions that we addressed in our activist guide to Hep C diagnostics. It's available in 4 languages and meant to serve as an all-encompassing package of learning materials to encourage participatory learning. It's organized into 6 sections and covers diagnostics basics, WHO testing guidelines, different screening strategies, a simplified diagnostics algorithm, an overview of the barriers, and activist lessons.
Just last slide, thank you.
So I guess moving along, I wanted to also show the next slide on MapCrowd. So this really is a tool to encourage activists to engage with Ministries of Health. This is a free public crowdsourced database that includes data from 44 countries by 60 in-country contributors. And I'd invite you to take a look at our issue brief on diagnostics, which was collected over 6 months and includes information on private and public sector pricing. Two key findings are that diagnostics costs in low and middle income countries contribute to the majority of people being left undiagnosed and untreated. And we were also able to compare the cost of test and treat programs in 29 countries. Next slide, please. This is our community checklist, also an advocacy material that is to be used by community advocates when looking at each aspect of the country's dashboard or Hep C care cascade. And so we suggested different questions for advocates that they could ask to the Ministries of Health, which can open up a dialogue and obtain important updates. Next slide. So these are a few of the specific lessons that we learned from our project together. And it also emphasizes the importance of community engagement in national elimination processes. Last slide. So thank you. It's really inspiring to see this really dedicated and diverse network of government representatives, hepatitis specialists, and other healthcare workers. And I'd like to express my immense gratitude to FIND and Unitaid and to the incredible community advocates in this project for their tireless, often underpaid work, who are committed to removing treatment and diagnostics barriers and making sure everyone who needs it can access the cure. Let's continue this momentum to secure global funding and to include community engagement in national and state budget allocations. The materials I mentioned are available via the websites and links here. And please consider TAG as a resource when planning community engagement in your hepatitis elimination strategies. Thank you, and over to the next presenter.
Thank you so much, Bryn, and for sharing those very valuable resources. So we need to move swiftly now to our final speaker. This is Maria Donatelli, who's the Senior Partnerships Manager for Coalition Plus. It's been an important partner in this project, and also Anishara Karanisi, who's the manager of the Hep C project with the Malaysian AIDS Council. Maria, and then we need to move straight on to the Q&A and concluding remarks. Over, thank you.
Thank you, Philippa. Good afternoon, everybody. I'm very glad to be here, and I want to thank FIND for this opportunity. I will be very brief because I believe that images will speak louder than anything I can say. I just wanted to say that Coalition Plus and FIND have collaborated for a few years now, mainly in Malaysia and India. In both countries, this collaboration strengthened testing opportunities for the most vulnerable populations. This was possible not only through the access given to communities to find facilities, but also through the support that FIND gave to community workers by making possible the organization of screening camps in remote areas through the donation of RDTs. Coalition Plus appreciate the recognition that FIND gave to community work. But this, unfortunately, it's not a given today. So that is why Coalition Plus, in order to advocate for the recognition of community work, recently shot a video in collaboration with partners in India, Malaysia, Morocco, and Colombia. This video shows how community workers are crucial in the fight towards HCV elimination and how they have become even more crucial during the health crisis we are living today. I will stop here, and I'm happy to present on behalf of Coalition Plus, MTAG Plus, MAC, DMP Plus, ALCS, Temeride, and Pharma, the film A Virus Won't Stop Us. Thank you. You can launch the film now.
Hola, mi nombre es María Angélica Jiménez.
Assalamu alaikum. Je m'appelle Ali Ladham.
Hi, my name is Vincent.
Jilin Hasna, تدخين ميدانية.
Mi nombre es Hugo Castro.
My name is Ebert Low.
My name is Petra.
Hi, my name is Sunita.
Hello there, my name is Jeremy.
My name is Lun Gante.
فبالاضافه للخرجات الميدانيه اللي كنعملوها خصوصا في هذه الجائحه ديال كورونا، كتفنا من الخرجات باش اننا نغطيو ما امكن بقدر كبير الاماكن اللي كيتواجدوا فيها الدراري. كنعرفوا واضح انه في خلال الحجر الصحي كان صعيب بزاف ان الدراري تنتقل ما بين الاحياء ديال مدينه تطوان وكاملين مع الحجر الصحي. واش الغبره موجوده هنا في الرينكول؟
لا قليله.
وكيفاش حتى كتوصلوا لها؟ واش كتجي من تطوان ولا؟
ما كيجيو الدراري كيطلعوا من تطوان يتسخروا، هذا كيجمع مع هذا كيعاونوا بعضياتهم وكيطلعوا يتسخروا.
هاد السعاده يعطيكم الماتريال اللي هو دائما موفر باش ما نلتقاش ليباتيت بيناتكم، كل واحد والتوبو ديالو كما قلتوا دابا. في نفس الوقت نفس الشيء بالنسبه للسيده عاود نحاولوا عاود كل واحد بحال دابا الدراري اللي كتلاقاهم خاص كل واحد يكون عنده الشواك. الحمد لله حنا دابا الجمعيه دائما هنا، السعيد دائما هنا، خذوا منه الشواك اللي خصو الشواك، كاين بريزرفاتيف باش ما تصابوش في السيده.
خليو لك هي في سميتو، خليهم لك في هذيك لابوار، خليهم لك في هذيك سميتو تما.
شكرا.
كاين شي حاجه ولا هذه راه عندك رقم الهاتف ديالنا، اي حاجه اتصل بنا.
شكرا، انتم سمحوا لي بزاف. والله
हॉस्पिटल में वापस आता बंदे ऐसा ही फिर होता बीमार होगा कि नशा खाने
They were homeless and they were living on streets, and police was not allowing them to stay on the streets. Also, they were beaten up many times by the police people. They were not getting food to eat, so they were becoming more marginal and vulnerable to the situation.
DNDi is an organization of, by, and for people living with HIV/AIDS. If we cannot serve our community when they are in trouble, I don't see any reason why we should be here. So we fear corona, we fear we don't have nothing, but we are trying to do our best in times of when our community needs help. That's how we respond.
is one of my partner organization who serving people use drugs, female sex worker, transgender, and man sex male community.
Bila ada orang nak pergi awal syari ini kan nak tahu. Habis ya, dah. Terima kasih. Kabar? Banyak kan?
Sangat berbeza lah, banyak perbezaan dia lah. Sebelum sebelum COVID ni kita ada ramai customer, tapi sekarang ada virus COVID ni, so kita kurang lah, down sangat macam tu. Percuma saja.
Mari kita cek dulu, tak cek apa ni surat ada hari ni.
Okey.
Oh okey, 367.
Purpose of us putting together the PPE for the community, basically to help our community who are on the front line, especially some of the NGOs, outreach workers, who has to constantly go to meet the clients, and definitely they are of higher risk.
There is a vitamin C to be taken 1 day, 1 tablet. You take out one of the face mask, hand sanitizer. Okay. The final product, as you see here, will be like this.
Assalamualaikum dan salam sejahtera.
Apa ni semangat ni? Okay, thank you.
Di seluruh Malaysia lah, kepada komuniti PL-HIV dan komuniti Hep C.
Mi nombre es María Isabel Velázquez Romero. Mi rol en Teméride ha sido como par educadora durante 6 años ya. Pues anteriormente me inyectaba heroína.
Bueno, mi nombre es Julián David Patiño, soy actor par en Teméride. Consumí también pues como mucho tiempo. En este momento lo que hago es estar en calle, escuchar los pelados, entregarles el material, direccionarlos, ayudarles, enseñarles, educarlos en todo lo que tiene que ver con infecciones de transmisión sanguínea, hepatitis, VIH. En cuanto al COVID, a mí me parece que nos ha afectado bastante porque no podemos estar como en calle, nos limitan mucho, la policía también está encima de nosotros, no solo de nosotros, sino también de los chicos que están en calle.
No nos es permitido estar en lugares donde hay mucha circulación de personas y pues esto obviamente por temas de riesgo, entonces esto hace que nuestra actividad se vea limitada, se reduzca.
La verdad, desde que empezó eso de la pandemia y de la cuarentena, obviamente se ha hecho más difícil conseguir plata, conseguir la droga.
En este momento los chicos dejan de consumir un tiempo por la pandemia y vuelven a consumir, y ahí vamos a tener episodios de sobredosis cada vez como más graves.
Se ha presentado eventos de sobredosis que obviamente por el incremento del consumo en algunas personas y por las mezclas que se acostumbran han ocasionado problemas serios que han sido atendidos con naloxona. Hemos aportado naloxona a líderes comunitarios para que estén atentos cuando se presenten estas situaciones y puedan atenderlos de manera adecuada. Esos casos sea donde se use. Cuando una persona tenga una sobredosis, ¿sí? Ustedes ya conocen los síntomas, ya saben qué le sucede a la persona, lo importante es que a la persona le puedan prestar ayudas. ¿Han visto casos de sobredosis en estos días?
Pero en estos momentos, que no es una condición normal, nos hemos visto obligados como a transformar algunas cosas. ¿Por qué? Por un lado, como organización, a nivel nacional no hay apoyo para nosotros, ni para organizaciones como las nuestras. Entonces estamos ahí, sin medidas de bioseguridad, sin garantías, tratando pues de hacer el trabajo, adecuándonos sin tener que exponernos. Hemos tenido que adaptarnos porque la condición se vuelve para nuestros usuarios cada vez más precaria.
Thank you. Thank you to Maria and to Anishia.
Mi nombre es María Jiménez.
Thank you, Dr. Philippa. Hello, everyone. Okay, so for today, actually, I'll talk about community workers' role and also community advocates' role in addressing the national hepatitis C response in Malaysia. Next slide, please. Okay, so at Nation AIDS Council, so we try to have 3 different approaches. The first approaches will be in the term of programmatic. So at Nation AIDS Council, actually we are having about 32, we are doing about 32 harm reduction site where we have about 193 outreach worker and also case worker at all over Malaysia. So currently with the current HIV program, so we have integrated with the hepatitis C program where usually the key population will bring for HIV testing, will bring for HIV services for methadone and STI. So we integrated with hepatitis where they bring them for testing for HCV as well. Okay, then the second will be on a community response, which we're reaching out at the most at risk population through online and offline outreach. Before this, we used to have the face-to-face meetings, means they meet the client at the ground, but COVID pandemic had teach us that the online outreach are far more feasible. So now we have expanded our services to more online, which is they'll call the clients, discuss with the clients, and set up interview, a medical appointment with the local healthcare clinic so that they can refer for testing and treatment. Okay, then the second under the community response, we also have education and training for outreach worker and case worker in order to disseminate hepatitis C information to the key populations. So we educate, we train the outreach worker with the national training, and also at the we also have the information booklet which is on hepatitis C, and also we also have MTech also have with their toolkits, so which is really helpful for the outreach and community workers. Okay, then at the same time we also with the collaboration with the state health departments, so we also have piloted some site for community-based testing for hepatitis C. Okay, then we just hope that it will be expanded to all the sites by next year. Okay, we already have the programmatic approach. The second is the community response, and while the third is strengthening the healthcare system, which we have developed a module, we call it HOPE module, with the Ministry of Health in Malaysia, with the CSOs, with the key populations to have a sensitization training for healthcare workers to reduce stigma and discrimination, so that when they can receive, they can accept the key population by giving them treatment. Next slide, please. Okay, beside that, multi-sectoral partnership plays a very important role as well, because we cannot work alone. Okay, we need all level of parties, including the CSOs, the Ministry of Health, the government, the international organization, the regional organizations, all of them to actually to ensure that we can eliminate Hep C together by 2030. So there you can see that the political engagement, which is we have very good support from the government, we have a good support from the CSO, we have good support from Ministry of Health, and also from international organization as well, to help us to with the community workers, and also for the case workers, and also community advocates plays very important role. Before this, we don't have medicine, but throughout with the advocate from the community through MTech and other coalitions really helps. For now, we can have free treatment for all. And I also want to say that our next step is to meet the target of National Hepatitis Strategic Plan to eliminate hepatitis C infection in Malaysia. So we believe that by working together with Ministry of Health, MTech, our partner organization, to bring the community for testing and treatment, and with the expansion of hepatitis treatment at the primary care clinics. So it's very much possible for Malaysia to be known not only for control of COVID-19, but also reducing the infection of viral hepatitis C among Malaysians. Also, I would like to thank Coalition Plus and also Unitaid for the funding and providing technical support for us to realize this agenda at the community level and continue to support the Ministry of Health Malaysia. Next slide. Thank you.
Thank you so much to Bryn, to Maria, to Anashia, and thank you for the great video. They say a picture tells 1,000 words, and I think that video was 10,000 words. And thank you also for really bringing in the community engagement during COVID. That's very relevant. So we have just a short time remaining. I would like to ask just a general question to all of the community panelists, and just to be reflecting on this while I'm also then asking Jean-Michel the quick question from the earlier session. So the question I would like the community team to reflect on is really, what are some of the innovations and good ideas in community engagement learned from the COVID response about how we might be doing things differently in the future in terms of really maximizing that community engagement. So if you could just reflect on that while I ask Jean-Michel a question which I was not able to ask earlier about the positioning of SOFRAV. DNDi has been doing, has played an important part in the FIND project in Malaysia in many ways, but you highlighted the issue of SOFRAV. So where do you see the positioning of SOFRAV relative to SOFDAC? It's not yet in the WHO guidelines, but clearly a very potentially important regimen going forward. Just a brief response, and then I'll turn to the community team for the response to my general question. Thank you. Jean-Michel.
So, yes, I was just trying to start my video. So I think, you know, okay, sorry. Most of the people that are being treated around the world are being treated with SOFDAC. So SOFDAC is really, you know, an amazing treatment option. It's affordable, it's cheap, but it also has some issues. It has drug-drug interaction issues. It has also issues with genotype 3. These problems are solved with Rabidasvir. So I think the two drugs, the two NS5 inhibitors, the Daclazvir and the Rabidasvir, can be really complementary treatment option in the toolbox of the doctors and nurses, hopefully, that will be treating HCV patients. You know, I think we need as many DAs as possible, as many pan-genotype DAs as possible available in every country, and not just one treatment option. And I think the Rabidasvir brings competition to a market that would otherwise be probably controlled by one or two products. So I think it's really an important tool in the treatment options of doctors.
Thank you so much, Jean-Michel, for that swift response. And just very brief remarks, Maria, Bryn, Anashia, on the issue of COVID innovations in community engagement. And then I will just conclude with some key remarks before handing back to FIND and WHA. Please go ahead.
Well, for me, what is important, and we could see it in Malaysia, for example, but also in some states in India, is that the governments must really rely on community workers. We have the expertise, we know how to deal with the most affected populations, and in cases like the one that COVID presented to us, the health services were not enough. So we are there, we are experts, we are knowledgeable, we should be able to do our work with the support of the government. Thank you.
Thank you so much. Any points to add? Otherwise, I will conclude. Bryn, Anashia?
Yeah,
yes.
Yes, thank you. So I do defer to colleagues who have actually who are working on the ground. I guess like my observations are that in these virtual times, there needs to be this ongoing relationship and communication with the health authorities to ensure that information is being shared, that any sort of progress that is made on hepatitis C, that there is that ongoing dialogue, and there may be virtual meetings and various other coordination that could take place. The other side of it is, I think, fixing some of the administrative barriers. So lifting treatment restrictions, prior authorizations, registering and accelerating, getting treatment access into different countries, and also some of the innovations related to take home and delivery, of medications, including OST. The other side of it should be also thinking about decriminalizing drugs and decriminalizing people who use drugs. And this is one of the things that I think can be done in a policy manner, and not necessarily having to rely on in-person meetings and such to do so. So let's think about the bureaucratic barriers as well. I'd like to hand it over to our community members who are working on the ground now.
Anisha.
For us, actually, I think the most important thing that we're seeing, because post-COVID, we have changed our approach in reaching the clients. Okay, even though the COVID has also teach us that even though treatment also can do through postage and so on. So it's kind of different approaches which is we done at the community level. And also I just want to say that always community makes the difference. So without communities, I think we cannot do anything. We cannot move anything. That's all. Thanks.
Thank you so much. So just final remarks and really excellent presentations. Thank you to all the speakers. I think key messages, community center stage, all aspects of the response. And really, we've learned through COVID that the community is critical to maintaining essential services, and hepatitis testing and treatment has been hit hard, as in other disease areas. I think the other message from the earlier session is decentralized testing is absolutely the goal, but we need to think about the yield. It's high at harm reduction sites. We saw that with Manipur, Myanmar and Georgia, ARV clinics in Punjab, lower in Delhi polyclinics, and Malaysia with primary care somewhat in between. Best of all, though, is the decentralized testing and treatment at the same site. We saw really good results with Myanmar and Manipur. That wasn't presented today. And where patients needed to move, were moving site, as in Georgia and Punjab, the linkage was somewhat lower. So the importance of trying to integrate testing and treatment, point of care viral load can play an important role, but really its impact is maximized if treatment is at the same site. So I think those are some overarching messages from the studies and the key message on community engagement. So thank you so much for the opportunity to moderate this. Over to Soniel. Thank you.
Great. Thank you, Philippa, and thank you to our panelists, and thank you for everybody that participated today. We really appreciate it. Also, we're glad that almost 200 people joined us on the Zoom, and plus the live streaming on Facebook. So it's great that people are interested in this. And so my takeaway is, how can all of us work together to maximize this? We're in a challenging space, not only with COVID, but before COVID. Hepatitis, we don't have necessarily the resources that we would like on a global level to tackle this. So it just requires that all of us come together in partnership and do what we can to move this forward. So thank you very much to everyone. I hope you have an excellent day. Thank you.
Thank you. Thank you.
Thank you. Thank you very much. Thank you, everybody.
Thank you very much. Thank you. Bye.
Bye.
Thanks.
All panelists.
want to eliminate HCV, you've got to look at three perspectives. One is prevention, one is treatment, and one is diagnosis.
So FINE and DNDi are both non-for-profit organizations. We're quite complementary in the sense that we focus on different aspects of access to treatment. DNDi focus on medicines and FINE focus on testing and screening. So the two put together means we can work together with the Ministry of Health to simplify the test and treat algorithm and bring more effectively and more cheaply treatment to all Malaysians.
In fact, the Ministry of Health is looking at point-of-care testing. So we hope that in future, more and more diseases, non-communicable diseases as well as infectious diseases, will be diagnosed at the level of the clinics and the community using point-of-care tests.
I'm very optimistic. Malaysia is already on track. Even though we have not get that recognition yet, but I can see that we are already on track towards elimination of virus in 2030, and they all can do the same thing as well if they can emulate or they can try to study or learn from what we have done.